Having worked on bortezomib, which more than 20 years ago it seems now, was the first drug ever approved for mantle cell lymphoma. There have been gigantic leaps in our ability to refine treatment ideas and treatment recommendations for specific patients. And I think one of the big advances we made came biologically, and that was recognizing that mantle cell is not one disease. And many of the studies we do, even the more recent ones still, tend to lump all patients into a pot. But increasingly we recognize that the proliferative rate, or Ki67, is an important determinant for many patients. And patients with very aggressive disease might benefit from more aggressive therapy up front versus patients with less aggressive disease. Maybe we can take a more conservative approach like we're used to using in patients with indolent follicular lymphoma and others. Unquestionably, over the years, the approval of proteasome inhibitors like bortezomib, the approval of lenalidomide, the approval of ibrutinib, and now, as you mentioned, the approval of acalabrutinib really broadened that portfolio of agents that we have to manage the disease. We still don't know a lot about how these agents work as a function of that biological context. But that being said, acalabrutinib is a next generation BTK inhibitor. And we know the data from ibrutinib is highly favorable, all the data published by Michael Wang and others. And acalabrutinib is actually felt to be a cleaner, more selective BTK inhibitor. So if you look at the kinome scan, you actually see that acalabrutinib hits far fewer kinases compared to ibrutinib, and the thought is that that selectivity translates into better tolerability, maybe not necessarily better efficacy, but if you're hitting fewer off-target effects, you might reduce some of that associated toxicity. So that has been the story for acalabrutinib development in CLL, where many of those side effects that we see with ibrutinib, in particular the AFib, you still see some, but you see less. In particular, some of the bruising and other side effects, generally all of them appear to be markedly less with acalabrutinib. And what we see in mantle cell lymphoma is also fairly encouraging. We see very, very good response rates. We see a very good complete response rate. And those responses, when we look at the time to event analyses, we haven't reached the median yet for median duration of response, for example. So I think I just started my first patient on this drug last week. And it's a patient that came in with a cardiac history, and why tempt fate? We started acalabrutinib first, and we'll see how that patient does. But for my other patients with mantle cell, using ibrutinib and or lenalidomide plus Rituxan has been game-changing, and in particular, especially for patients with indolent disease, where you're really trying to manage it with the least toxic approach possible.